A very good evening to all. Today, I welcome to this concluding session of season 3 of the Journal Club meeting. This is a very interesting topic, a glaucoma topic, which we have chosen today. And today, we have very distinguished faculty, Dr. Harsh Kumar, who is a Padma Shri recipient and a very senior glaucoma consultant at Center for Sight in New Delhi of 38 years plus practice and lot of 86 plus index publications. So it'll be really a treat to hear him on and discuss on today's topic. And today we have another distinguished glaucoma specialist, Dr. Manish Shah, who's a very close dear friend of mine. And he is also of 25 years plus practice in glaucoma and very experienced person. So definitely it'll be a really a treat to hear them both and discuss this topic thoroughly. Today, this has been a very nice experience, the season 3, with the support of Dr. Santosh Agarwal and the Dr. Nitin Balkrishnan from the BOA team and the MOS team have always supported us. I thank the dynamic team of of mine, with Dr. Parul Deshpande, Dr. Zain Khatib, Dr. Neeraj Israni, and the most important is Dr. Sabyasachi, who has spearheaded our statistician part of the discussion and really has brought it out how the article and dissected whether it's relevant or not. So with this dynamic team, I would further continue in the season 4. And without much further ado, I would ask President MOS to give say 2 words.
Yeah, thank you, Dr. Vaishal. Good evening, everyone. Myself, Dr. Santosh Agrawal, President MOS, welcome you all to this distinctive MOS-BOA Journal Club Season 3. On behalf of MOS, I congratulate Dr. Vaishal Kenia, Chairman, JC Committee, and his esteemed team, Dr. Parul, Dr. Sabyasachi, Dr. Zain, Dr. Neeraj, for successfully organizing this JC for last 3 years. Today's topic would unveil the factual information in regards to laser versus topical anti-glaucoma medicines in glaucoma and ocular hypertension. Journal Club unfolds many such facts to aid in decision making while dealing with such facts in various clinical conditions. This certainly fosters evidence-based practice or preferred practice pattern and enhance our standard of practice manifold. JC also offers opportunity to our PGs and fellows to imbibe the current affairs in ophthalmology, which definitely help them in their exams as well. How to do research, how to write a research article, statistical analysis, and other aspects of research methodology can also be learned during JC meeting. I express my gratitude towards Dr. Rita Dhamankar, Dr. Manish Shah, and Dr. Harsh Kumar for sparing their invaluable time to discuss and offer their pearls of wisdom in today's JC meeting. I wish all the very best to Dr. Sampada for her presentation of the very important journal article today. I am looking forward to a fruitful and great discussion today. Thank you all. Regards. Over to Vaishal, please.
Fine. So we ask Dr. Sampada to present her article of today. Sampada, you can go ahead. And then Dr. Parul and Dr. Zain will moderate the meeting.
So Dr. Sampada Chitra is from, she's a glaucoma fellow currently at Lakshmi Eye Institute, and her mentor is Dr. Rita Damankar, who will not be able to join us today. So with this, Sampada, can you share your article? So this is basically dealing with the extended 6-year results of light therapy versus the medical management. So Sampada?
Yes.
Yeah, you can present the article there. You can see it.
Good evening, everyone. I'll start my
Sampada, we are not able to hear you. We've lost you.
Am I audible now?
Yeah. You can switch off your video.
Switch off your video, yeah.
I'll switch off my video.
Yeah.
We are losing you in between.
Stop video and present with your video. Just click on the video icon.
Stop.
Yeah, perfect.
So the article light trial is American Academy of Ophthalmology in the year 2023. The aim of the study was to study the efficacy of the SLT as a primary treatment for the open eye.
We still can't hear you properly.
And to compare the health-related quality of life after primary treatment and IOP lowering agents at the end of 6 years. So, till now, is SLT may delay the progression of ocular hypertension and in patients of OAGs, and it is mainly used for treatment naive patients and used for the mild to moderate disease. But what needs to be found out is, as it's effective for the first line treatment for the glaucoma management, its effectiveness in the advanced disease delaying the surgery, and its effectiveness in delaying the incisional glaucoma surgery control of the disease. So SLT is mainly an filtration surgery where IOP is not controlled with the medications. The laser used is a frequency double Nd:YAG laser, pulse duration being for the 3 nanoseconds and the spot microns. The IOP lowering effect is from 18% to 30%, as effective as ALT in the initial 6 months of treatment, and it does not cause any permanent scarring of the. Thus, it prevents the increase in the intraocular pressure and pars formation. Mainly acts on the melanin-laden pigments of the cells of the trap meshwork without causing any thermal damage to the adjacent structures. So the main effect, the pigmented laser energy induces a biological response which causes a release of cytokines called as photothermiolysis, which results in the IOP reduction. Current study is a prospective multi-center randomized control trial. It held in October 2012 to October 2014, and the participants were newly previously untreated OHT and open angle glaucoma patients which are both eyes and who qualified the NIC guidelines at that time. For the patients were newly diagnosed with ocular hypertension and were fit for treatment according to the NIC guidelines with visual field loss of more than minus 12 decibels in the better eye or equal to minus 15 decibels in the patients with age more than 18 years, BCV of 636 or better in the treated eye, no previous intraocular surgeries, except uneventful phacoemulsification. The patients having symptomatic cataracts or patients who are having UV with any other treatment for the other ophthalmic conditions, and inadequate trabecular meshwork view, or who were unable to sit. Organization was done using a web-based system so as to allocate them in IOP lowering group or in the SLT group, and all measurements influencing the treatment were done by the masked observers, while the clinician and the patients who were taking the treatment were. The disease definitions followed the NIC thresholds at that time, where the target were for ocular hypertensives and mild open angle glaucoma patients were 20%. For the moderate and the advanced disease were 30% reduction. The decision was documented according to the decision supports and required by a confirmation was required by a consultant ophthalmologist. Treatment escalation followed the international guidelines of the European Glaucoma Society. Academy of Ophthalmology preferred practice patterns, and the Southeast Asia glaucoma interest groups. Then, when they escalated the treatment, were the following criteria. Intraocular pressure is more than target IOP by 4 millimeters of mercury, or when the IOP not more than 4, but it is more than target, but there is a evidence of progression by the visual field analysis, and when the intraocular pressure is good in control, there is a documented progression. And if the deterioration is noticed, then the target at 20%, and if the disease was stable on 2 successive visits, when the intraocular pressure is more but more than the target, in this cases the target IOP was revised upwards. So how they treated the patients with SLT were at 360 degree of the trabecular meshwork was treated with 100 non-overlapping spots, 25 energy being 0.3 to 1.4 millijoules, and the first 36 months the only if required one additional SLT was given, and next escalation was the anti, and in next 3 years the third SLT was allowed. For AGM, the categories were defined according to the NIC guidelines, where the first line agents were PGI blockers, third were topical CA anhydrase inhibitors, and single drop advice after randomization, and if required additional escalation was with the additional medications or sometimes switch to the SLT group. The primary outcome measure was with respect to the health of the scores of the health related quality of life, and secondary outcomes were clinical effectiveness, reporting of the adverse events with the drop-free IOP control and the disease progression. The study was carried out with the good clinical practice guidelines and adhered to
We are unable to hear.
secondary outcome was analyzed using the linear regression after randomization, and unit was the patient, and in cases of patient where both the eyes were included, the worst eye consideration for the assessment of the intraocular pressure and the visual field analysis is less than 0.05 is considered as a statistical significance. In the initial 3 years of period, total 718 patients were randomized. Group 362 in the drops group. Out of them, 693 completed. 633 patients entered in the 3 years of extension period, and out of them, 524 completed the 6 years of extension. So current data in this article is based on the 524 patients completing the 6 years of the trial. So the age in both the groups is comparable. 63 being the mean age, the sex ratio and the ethnicity in both the groups were comparable. Of patients allocated in the ocular hypertension and open angle glaucomas also were comparable. And the patients were analyzed depending upon the health related at the start of the trial, that is at the 36 months, all the 4 parameters, the scores were comparable, but at the end of 6 years, that is 72, there were worse scores in the drops group for the glaucoma symptom scale compared to the trabecular group. Then the IOP, which is achieved, is equally and comparable in both the groups, with 3.2 in the drops groups and 92 in the SLT group. The disease was found to be significantly lower in the SLT group compared to the drop. The drop-free IOP interval 6 years was significantly more in the SLT group, the drops group. Then there were several IOP revisions, and it was comparable in both the groups. The amount of trap surgeries which are required in the initial 3 years was 0 SLT group, and after 3 years it was around it was 13 compared to the 32 in the drops group. The absolute value of the intraocular pressure at the end of 6 years in the drops group, which is quite less compared to the SLT group. This graph will mainly show of the time required for the disease progression, which is quite less in the to the drops arm. The time required so as to undergo surgery is also very much less in the SLT arm compared to the drops group. Coming to the adverse events, no sight-threatening adverse events were reported in patients with SLT treatment, and ocular adverse events were slightly less in the SLT compared to the drops groups at the end of 6 years. And any systemic adverse events were also comparable in both the groups. So data after 3 years suggests that the initial treatment with SLT provided the drop-free IOP control in 78% of the eyes. The need for the glaucoma and cataract surgery compared to the IOP lowering treatment. And eyes in SLT demonstrate less frequent progression to the more advanced stage of the glaucoma. After 6 years, the results also were the similar, where the progression in the SLT group and drop-free IOP control is 70% 6 years. So the light trial used eye-specific target pressures, which could be revised in the absence of evident deterioration. IOP was reassessed in the evidence of disease stability, which was applied to both treatment arms. Field analysis and disc imaging provided the evidence for the stability. Upward and downward revisions are comparable in both the groups. Who received the initial treatment as a SLT, while at the end of 6 years, the was 3 times less in eyes as compared in SLT group compared to eyes who initially received the IOP lowering agents. Of the study are that it did not take into consideration the systemic comorbidity which might affect the disease progression, like hypertension or diabetes, and the number of patients with ocular hypertension or in patients having mild open angle glaucomas were so where the stringent IOP control may not be required. So the selective laser trabeculoplasty, according to, is a safe treatment for the open angle glaucomas and patients having ocular hypertensions. It better long-term disease control with initial drop in the intraocular pressures. After 6 months, it reduces the need for incisional glaucoma and cataract surgeries, and the success depend upon the disease severity and associated comorbidities. Coming to the MARI protocol, the purpose of the study in this are defined. The study design and type is prospective multicenter randomized control trial. The criteria for randomization and masking were also clearly mentioned. Groups of ocular hypertension and open angle glaucomas were clearly defined. Disease progression and target IOP were clearly mentioned, and patients in the glaucoma are divided according to its severity, and randomization and masking is clearly mentioned. The methods of performing SLT were mentioned. Target IOP and treatment escalations were very the appropriate statistical techniques were used to assess the, and the data was well depicted in the tabular and graphical format. Which reduces the need for the incisional glaucoma surgery at 6 years follow-up. SLT used as a first line treatment for the glaucoma management. It can prove as a better for patients with advanced disease in the terms of delaying the surgery. But more longitudinal are required so as to know its effectiveness in advanced disease for delaying the need of incisional surgery.
Thank you, Sampada, for a
Yes.
wonderful presentation. Now, with this, I would request Dr. Sabyasachi Sengupta to just take over the statistical part of the article.
Sampada, you can stop sharing your screen, please.
Yes, yes.
Dr. Sengupta?
Yeah.
Yeah.
Very good evening, everyone. And as always, I'll quickly share my PDF.
You have totally changed. Huh? Looks.
You're seeing me after 3 months, so
Yeah.
well, actually, we'll talk about the light trial a little bit, and so this is one of the major clinical trials which have evolved, which has actually evolved glaucoma management after the initial set of 3 or 4 major trials like the ocular hypertension treatment trial and the SIGITs and all of those, right? So this is almost a decade after those finished. So it's and the authors clearly say that once the 3-year results were released, the European Society and the American Society of Glaucoma Surgeons actually changed their recommendations and are now recommending SLT as the first treatment of choice, right? So that's also something new for me because I don't deal with glaucoma always. So so I'm not really sure how many of us in India are actually taking to SLT to treat glaucoma as the primary treatment even before starting drops. So it would be interesting to even ask the glaucoma community about this. So once you have such a major clinical trial, it's let's understand that it's difficult to critique such a paper, but I'll give you a little insight into how we can still critique such a paper. First and foremost, when they talk about the purpose, they say this article reports health-related quality of life. So when a clinical trial is designed, most of the times health-related quality of life is not the primary outcome measure. It's either it's safety or efficacy or one of those. So as soon as you start talking about some other measures which were not the primary focus of the study, we call this post hoc analysis. And most likely this is the post hoc analysis. Right? So post hoc means you are making the secondary outcome as the primary outcome and then actually analyzing the data and then reporting on your findings. Because you have a large sample size, it's perhaps all right, but I would still think that this is a post hoc. So the word post hoc means you are actually dealing with a secondary outcome as if it were a primary outcome. When you combine ocular hypertension and open angle glaucoma, most likely these are all early glaucomas, right? So there's no question about having mean deviations of minus 15 and minus 16 decibels, right? So most of these, as you will see the results, they are all below 12, and that was also the inclusion criteria. So combining the two, I'm not really sure how much it makes sense because a lot of the ocular hypertensions never convert to to open angle glaucoma, and about 20 to 23% of this patient population in both the groups were actually ocular hypertension. So perhaps a subgroup just looking at those with glaucoma, established glaucoma, might actually give us even more details. Now this is slit line, SLT arm were permitted a third SLT if necessary. So in the protocol, in the first 3 years, they were allowed 2 sessions of SLT. So, what are the number of sessions that should be reported in the results? That has not been reported, right? So, it seems as if it's just, at least in the abstract, it seems as if, it's one and done, and you're through with it. But that's not really the case. When you look at the results carefully, you'll note that a lot of the patients have actually repeated second or third sessions of SLT. Majority of have actually repeated more than 2 sessions, right? So SLT is one and done is perhaps not the take-home message when you look at this. Interestingly, this study allowed switch like from one group to the other. You can jump from one to the other group, and that is not very common in clinical trials, and that's quite brave of the authors to actually allow that. In the results, the comparison from at baseline is not mentioned. Did the two groups have, the SLT group and the drops group have the same mean deviation at baseline and all of that? There is a table there, but then there are no p-values. So at least there should be one line which says that at baseline they are all comparable to each other. as we know, the primary outcome that they talk about, there is quality of life. There is not much difference in the groups. Now, so in glaucoma, what is important is time. So when they say of eyes in SLT arm, 69.8% remained at or less than target IOP without the need for medical or surgical treatment. And the question is when, right? So at 2 years, at 3 years, at 4 years, the 69.8%, that is 70% success is at 6 years. So it's very important to know when these failures happen. That 30% actually had failure, right? So more eyes so here we use something called survival analysis, and we depict that using Kaplan-Meier plots, and that they have actually given later on. But then giving these percentages alone is not a good idea. So what they should actually report is cumulative success or cumulative failure. Cumulative means you are actually taking into consideration everything that happened at 2 years, at 3 years, at 4 years, at 5 years, that way. So, so let me show you an example of another paper, from the Arvind group, this which talks about RD. You're able to see this other screen as well, right? So here they say Kaplan-Meier estimate showed a cumulative probability, right? Cumulative, the word cumulative probability of failure was 9.5% with a confidence interval of 5.8 to 15.2 at 1 year. 27.8% at 2 years, 38.9, whatever, at 3 and 4 years. So this actually tells us the cumulative number as well as the, confidence interval. So let me go back here. So if 69.8% had success, that means 30% had failure. Now around that 30%, that, all patients will not have 30%, right? Some may have like 15, 16%. One group of patients may have 15% failure. Another group may have like 40% failure. So the 95% range is very important, which has not been given, unfortunately, which should be given. And, like you saw the Arvind paper, which talks about at 1 year and 2 year and 3 year, perhaps they could just talk it at 6 years between the two groups. So time is very, very important when we talk about glaucoma studies. Same thing is with trabeculectomy, right? So when was this trabeculectomy happening? Within the first 2 years, one group needed and the other group needed at 5th and 6th year, then it's still all right, right? So, say the SLT group needed some 13 eyes, needed trabeculectomy, but that was in the first year itself. Whereas these 32 eyes in the trabeculectomy group, in the drops group, they needed it at 4th and 5th year. As you can imagine, the numbers are all significantly different, as they say, but the time is entirely different, right? So, so that time factor has not been mentioned at all in the abstract, unfortunately. And when we talk about the conclusions, what about the health-related quality of life? They say selective laser trabeculoplasty, safe treatment, etc., providing better long-term disease control, and with reduced need for incisional glaucoma. But what about quality of life? That should also be mentioned, right? So that conclusion is perhaps a little bit, incomplete in terms of not mentioning what they were looking for. So they clearly say that after publication of 3-year results, international guidelines on the treatment of glaucoma have been updated. And if you look at the authorship, really who's who of glaucoma from the UK, and so it's not it's not surprising that they've actually influenced everything that is happening there, right? So lastly, I wanted to basically just take you through into the Kaplan-Meier curves. So these are these curves, right? I think Sampada has also put them up. So when you see these are failure rates. So at 2 years, if you extrapolate, this is the percentage of failure. There is about 10% failure at 2 years. Remember, these are all early glaucoma eyes. Only 10% have failed. At 4 years, about 16 to 18% or something have failed. At 6 years, about 20% have failed in the SLT group, and about 25% have failed in the drops group. And these are numbers at risk, and the denominator is about 300. So you see, these numbers are relatively close to each other, right? So, so I wouldn't really call SLT with multiple treatments necessary. And then many actually also having to shift over to drops, about 30% still needing some drops in some form or the other. Overall, yes, SLT as a first line treatment is all right, but then we need to still keep monitoring it relatively closely. And repeat SLTs, indications for repeat SLT we need to have them in mind, those cutoff points. And then when do you actually put patients on intraocular pressure lowering medication is also something that we should think about. And so it's that I did it once and it's fine. Patient will be fine till 6 years is perhaps not the right take home message if we are concluding something like that. So overall, these are a few of the the tips. So remember, in glaucoma studies, or I'll just stop my share. So in glaucoma studies or any of these studies where time is important, we need to look at it with that lens. So how soon or when? So that is something that we need to ask, and also kind of inculcate in the way we present, in the way we look at glaucoma papers, and the way we analyze our glaucoma papers. Thank you.
Yeah, thank you, Dr. Sengupta. So with this, I would open the questions to the panelists. So Dr. Harsh Kumar and Dr. Manisha, so your comments on the article as a glaucoma specialist.
Okay, I think first we must congratulate Sampada, because it was a mind-blowing article. It is not at all easy to
Yeah.
read it, I must say,
True.
and she very, very beautifully summarized the entire thing. One thing which both of them didn't bring out was the fact that 78% of the patients were white, and they were only 8% Asians.
Patients.
So it is very, very tricky to discuss any in great lengths, because I think, like Dr. Sabyasachi said very clearly, that Indians are very, very intelligent people. If it was something that good, everybody of us would be doing it. And we all hate trabeculectomies, we know that. But look at the number of people who are doing it, it is very, very low. And I have been talking to a couple of people who have, I have some experience, but I did around 2, 3 theses and I was impressed. Dr. Das has done thousands, and he told me that he was thrown out of SLT group light trial because he did not exit many of the things. So one has to take this with a pinch of salt, because our people definitely respond in a different manner. Not to say at all that SLT is not effective. It is very effective to begin with, but the effect in our patients do not last long. That is one part. The second part is that they have done. Now it is really surprising that none of the health-related quality of life. They did 3, 4 this thing type of analysis. So I totally failed to observe. And if you actually read through this, and thank you very much, Manish, for getting me here and all of you, because of that, I at least read what the hell it is all about. So all the 3 are missing the points, because they are actually, there's only a glaucoma symptom scale is the only one which is actually looking at itching and discomfort in the eyes and things like that. All the rest are visually. That is why they are similar. But how can putting so many drops as compared to a place where you are not putting drops give you similar results? It's not trials are chosen. And
So
now
we,
a lot of people are saying that you cannot take it as the end point. Yeah, Varun, yes. What were you asking?
we were not able to hear your last few comments. I don't know.
Oh,
The connection was not proper, I think.
now is it okay? The connection is okay?
Yeah.
Yeah, the health related quality of life trials are, if you look at the trials which are quoted here, most of them are saying on the visual aspect. But as we all know, the drops actually create a different kind of a problem for us, and especially the side effects, which could be allergies, redness, itching, so many other things. So how can they be similar outcomes? It is very, very difficult, because they didn't choose the right trials over there. So there are a couple of other things, but let Manish also say something, then I'll come back to you.
Yeah. Dr. Manish.
Yeah, so definitely the presentation was fantastic, and the way to go about this, though it is a landmark study which has spectacular results, and but as pointed out correctly by Sampada as well as by Sabyasachi, is that the way they have collected the data is a little confusing, in the sense is that they have mixed up the 2 groups of open angle and ocular hypertension, which is actually very different groups. And I am not very sure when the patient started using drops, and maybe that has made the results a little unrealistic. So we have all been using SLTs. The problem with SLT is that, number one, when a patient comes to us who has glaucoma and is made to understand that the treatment is pressure reduction and that can be achieved by drops, and you offer SLT, but they are very happy if the SLT is going to do the trick forever. But that is not true. And even in this case, they have brought it out quite clearly in the study that SLT required repeat SLT procedures to be done. And this is exactly what patients are not very happy to accept, is that you will need to keep doing this procedure again and again. So they have a outlook is that if you have to do something once and that holds for a pretty long time, they are happy to do it, and without side effects. But if they have to keep doing something again and again, like putting drops, they are okay, because they say that drops you can get it themselves, put it themselves, and if in the future things change, the other options are always available to them. So that is why convincing patients for SLT, whether the outcomes of this trial and if they are shared with the patients and general public also, I still don't think patients will be very happy to accept SLT as the primary treatment to start with, especially the ocular hypertensives, because when we see ocular hypertensives, we tell them that only 10% progress into glaucoma in 5 years. That's what the OHT trial told us. And that also, if you select using risk factors, there are a very small number of ocular hypertensives you really need to treat. And if you tell them that you don't have glaucoma just now, but we are only treating you for risk factor, they are not very happy to do an SLT, much happier to accept a drop. Having said that, I'll tell you about another laser procedure, which is the laser iridotomy, which definitely has much more protective effect than SLT, because it's to be done only once. But convincing patients to get a laser iridotomy done in the angle closure suspect category itself is quite a task. So I am not very convinced that even with the data from this trial that it's going to change our way we treat our patients. However, it is an eye-opener. Definitely, I have been using SLT over the last 10, 15 years in selective cases, and definitely it has shown, as Harsh said, it's not that SLT does not work. SLT definitely does work, and it does help a lot in the given situation when you select it correctly. But it definitely needs to be repeated. I think there was a study which was done in AIMS. Harsh knows very well when he was in AIMS, but that was done with ALT. And the data, when they analyzed the data over a long period, over I think 6 years or 8 years or 10 years after, they found that there was a subgroup of patients who continued to have the effect of the one ALT for a pretty long time. Harsh, correct me if I am wrong.
Yeah.
So there are cases where the effect of the treatment does last pretty long. The problem is we can't predict in which patient it will work, in which patient it will need repeating, and in which patients the effect will last very long. So this is the real problem with SLT, and this study is not bringing out any extra factors like which will predict which patient is likely to respond well to the SLT. That is one of the problems I see.
So, Dr. Manish, I just had one question, is that when we talk about the result of the study, so we do not have any study in the Indian continent which has been done on SLT. So,
there is a study by Pandav.
okay. So,
Dr.
what are the results for that study? Because
They have done a very small study, and it was primarily in the secondary patients.
Okay.
And so that was another point, that like what rightly Manish said, that most of the patient, by the time they come to us, all of us, they are already on some drops. So getting a treatment naive patient is extremely difficult. And like Manish rightly said, no, it is practically impossible, because they think that, okay, you do a thing and I'm done. So if they run away and they don't come back, then you are in more trouble. Because if the glaucoma worsens, you will not be able to keep them in track. And there's another study by Vinay, but that was primarily in JOAG. And there he was able to see that in which he could defined the trabecular meshwork and the Schlemm's canal properly, those were the people who were able to respond much better to SLT than those in which the canal was not properly visualized by means. So these are the only two primary studies. I don't know if there is any study by South, because Ariga and all keep talking about these things. Are there no more studies, Manish or Sampada? Did you read?
No, I'm not aware. I'm not aware of studies being done, reported at least.
Yeah, these are
results.
the only two in Indian continent that I could come through, and there was another foreigner who had done a detailed study on all the SLTs done here and there, and then he reported that in Indian eyes the success was only around 40%.
So what is the reason for less success in Indian eyes?
That nobody really knows. It may be something to do with the pigmentation, because these are all the lighter eyes, in which such good results are being shown. So that is one possibility.
And one more thing I would like to add, in this study, they have reported not a single patient with uveitis after doing SLT. But I have seen patients in Indian scenario, not SLT done by colleagues, having quite significant uveitis in the immediate post-procedure time. So that is also one more point to keep in mind, that some cases do get uveitis, and probably my guess is that the patients in whom the trabecular meshwork band is a bit narrow, and the SLT beam is quite a big, large beam, 200 microns. There is overlap on the iris, and those are the patients who get uveitis.
So, is it okay that am I visible now?
Yeah.
Because I think this thing conked off, so I'm on the phone now.
Yes.
Yeah. Okay. Please go ahead. Yeah.
So in continuation to both the panelists' comments, SLT, Manish sir, you have said that you have done. So how often on an average do you have to repeat it? And what are your guidelines for doing and for repeating? Or do you start with anti-glaucoma, or do you give a trial? What are the indications in your
No,
experience?
I have not done a single patient as a virgin patient, because I find it very difficult to explain to the patient and get the patient convinced, unless only the patients who are having a lot of problems with eye drops, they are the ones who are ready to try this out. And they know that they have problems only after they have tried the eye drops. So there is no patient I have done who has never put eye drops. Now, having said that, my standard protocol for doing SLT is 360 degrees. I treat all the 4 quadrants, non-overlapping burns. So, and I do around 120. In this study, they have written 125 per quadrant, but I am doing 120 shots, all 360 degrees, using power or 1 millijoule to 1.2, usually going. But I usually give the shot and see the champagne bubble reaction, and then just step down a little bit. That is my protocol of titrating the energy. And I do all in one sitting. Some people are doing, half in one and half in the other. I do all in one sitting. And I put the patient post-operatively on NSAID. No steroids are to be used, because they seem to, it's well reported that they will alter the mechanism. So if you use steroids, the whole purpose of doing SLT is going to be lost. So you have to use NSAIDs for 15 days. The pressure reducing effect you start seeing about 10-15 days, but the best effect, it will take a month to happen. So it's not instantaneous. So I generally ask to continue the anti-glaucoma medications, and once I see the IOP coming down, then I start omitting or cutting off the glaucoma medications, as many as I can. Repeating, usually the effect definitely lasts for about a year and a half. 18 months, I have seen a lot of patients lasting. I have seen at least 50% patients, the effect lasting more than 2 years. But after that, it needs to be repeated, and repeat SLT also it comes back to the original level. So it is effective.
So, Dr. Manish, I had some question about the post-op management. So, what is the post-op management that you would recommend? And second thing, do you see any hypertensive phase
No,
post SLT?
I am not seen hypertensive phase, though technically any laser procedure can have IOP spike. Even YAG lasers, capsulotomies, everything we know and we act for it. But I haven't seen a significant hypertensive phase after SLT. Now, post-operatively, the patient is advised to continue the anti-glaucoma drops exactly as he's been putting, and additionally put a nepafenac for 3 times a day for 15 days.
Okay.
And follow-up is there definitely. Close follow-up is kept to see. The first follow-up will be around the second day or the third day to see how he's doing in general. Because as I said, I haven't seen in any patient I have treated, but I have seen uveitis in patients somebody else has treated. So I definitely think in some cases it can happen. And if there is uveitis, you will have to give steroids also. And then after that, I don't know how much the SLT is going to work. So that is a different matter. Then I follow up. I call them every 10 days. And as I said, the best IOP reducing effect you will usually see after a month.
So most of the patients, I think most of the people are using 360-degree SLT. So there are some publications which talk about 180 degrees also. So do you think that is also going to work, or
So initially if you see the original reports, they were all talking about 180 degrees only. Even I started with 180 degrees. And you see how it responds, and if required, do the 360. I switched after maybe around 15-20 cases of doing 180 degrees and doing that. I said this seems to be doing too much of work, and having to do it again and call the patient again. And patients also have, they start suspecting that this procedure is not a good procedure. Many doubts start appearing. So I started doing 360 degrees, and then I found out that almost everybody is doing 360 degrees, and this study is recommending 360 degrees.
So, Manish, what percentage of patients were successful? If you take all the naive patients, but you didn't do naive.
No, I haven't done a single naive patient. So success rate is exactly as the study has shown. The success rate is something like 70 to 80%. 20% don't show us useful response.
Because in our study, in what I did was 60 to 70%.
And how long does the effect last?
And again, secondary, Parul, the secondary glaucomas invariably can have a spike, and sometimes they just become uncontrolled also. So that was one trouble we had, especially in some cases of uveitis and traumatic this thing. So one has to be very careful. I think you better stick to primary glaucomas. Right.
So which are the cases of secondary glaucoma where you can recommend SLT as an additional therapy, or Dr. Harsh?
I think I after all that experience, I would say that one would preferably not do it. But if the patient is admitted with you, or you can really follow up and you are in trouble because the rest of the options may not be very valid, then you can definitely try.
And so what are the indications that you look at for SLT? So let's say if a patient is unilateral open angle glaucoma, or if you see a patient who has an ocular surface disease or the compliance is poor. So what is your selection criteria for SLT? So if you have to select in your group of patients, which are the patients you think you will subject to SLT?
So yeah, I think you already said all the criteria. That is absolutely the correct criteria, that yes, unilateral you would love to do because unilateral drops are going to be difficult. And if you know that the patient is not compliant, yes, that is one of the best things. And the angle should be well seen. That is one of the most important things. And the patient should be ready to follow.
Yeah.
He should be able to pay for the initial procedure and be ready to know that, yes, there may be 30 to 40% cases in which it will not work. And then he is ready to switch on, which maybe sometimes in practice is a little tricky part.
So me being a cornea surgeon, I do see a lot of ocular surface problems with anti-glaucoma medication, especially those which come out with, cicatricial complications. So there, probably we've seen 1 or 2 cases where SLT was performed to control the glaucoma, and that serves as an additional therapy,
Yes, definitely. Just one question to Sampada. Sampada, why every study takes patients more than 18 years of age?
Vincent, I don't know.
Sampada?
Any idea why they take patients? Or whenever you see studies, any idea?
Concentrated.
So I was also intrigued because both the visual fields and OCT, which are most of the important parameters, their databases start after 18 years of age. So they don't have the database for below that. That is why, for comparison's sake, that becomes very, very important. It's not because that those patients will not be compliant, because they may be 11-year-old chap can also follow and do the test, but there is no database on that. Please go ahead, Paru.
So, sir, now, yeah, any comments from anyone? Yeah.
No, I just wanted to know that as of today, if you are doing some laser procedure to the trabecular meshwork, is SLT the only option we have, which is considered reasonably successful, or there are some other forms of laser? I think Dr. Kakadia has come up with something called as traboclean or something like that. So, any experience with these sort of procedures?
And even comparison with the newer technology, incisional surgeries. So
I think that is a different
no, that is a different topic,
game.
but very rightly said, we got a machine known as the excimer laser trabeculoplasty. So that was a total machine by itself. In some Israeli chap had got it, and you would give this excimer laser spots in the meshwork. And obviously, we were initially very excited, but unfortunately, that also did not work. So I don't know of any other this thing. Manish, any idea of anything else going on?
So this traboclean, which is being talked about by R.C. Shah and Dr. Kakadia. So there is something called that high frequency treatment also. These are all, I have no personal experience, but they have...
Ultrasound, is it ultrasound?
Ultrasound, yes. Even this traboclean is ultrasound only.
So I think even Rita was doing something like, I'm not too sure, but...
Yeah, she was doing, that was treatment to the ciliary body. That was different.
Oh, okay.
So that
femtosecond laser has been contemplated on the research is going on for working on the trabecular meshwork.
Yeah, when you can do a bang and remove the trabecular meshwork by a 2 rupee needle and doing I really don't know what is the future there.
But SLT probably is the only thing that right now is considered the treatment to do at the trabecular meshwork, right? Non-surgical. That would be the consensus, right?
Yeah, that's right. That's right. As of now.
Okay. Sen Gupta sir, are you there? I had a question related to the study as well.
Yeah, go ahead.
Yeah. So, sir, you had said that, the primary outcome measure that they have taken would have been a kind of post hoc analysis thing. But my question is that in all their discussion, they have seen that actually the quality of life was not significant between the two groups. It was the same, and all their discussion and conclusion have pointed to the fact that SLT may be equal or better in terms of efficacy. They have not spoken in terms of quality of life. So why would they change that as the primary outcome measure when it did not have any importance?
Yeah, so primary outcome measure is predetermined or predefined. It's even before we start. And, every study can have only one primary outcome measure, and everything else is like secondary. So, for this kind of study, so because primary outcome measure is important for sample size calculations, for the way we analyze the data, interpret the data, and all of that. So, having a study like this, which is entirely based on quality of life, is, I don't think that is feasible as such. So, with all the funding there and with all the all the major things which were happening, so therefore that quality of life is not the primary outcome measure. And because there was not much difference in any case, they have not much. They have sort of shrugged it off, or sort of in at least they have not discussed it much in either the or the conclusion. So it's sort of a foregone conclusion that it's almost the same in both.
So they must have purpose of this study must have been to kind of prove that SLT would be superior because the quality of life would have been worse with medications. That's what I'm kind of interpreting. But they failed in doing that, because if both are equal, then actually the quality of life has not deteriorated with putting medicine. So is that what we have to take home from this?
So yeah, so then only the glaucoma symptom scale is the only one where there was, where the obviously the patient with the drops did worse, but then overall the quality of life was not affected much, even with putting drops. And the mean IOP was almost 1 millimeter mercury lower in the drops group. So that is something that Sampada did present, but then we didn't talk much about. So
yeah, so I think she spoke about that, saying that they did more trabeculectomies in that group. That is why probably the overall IOP at 6 years was lower. That could be one of the reasons.
Maybe.
Not only that, as I already told you, the scales that they selected were not meant for any of this, because all the patients were early. And if you look at the health-related quality of life scales and you read what is given in them, it would usually mean that there should be some significant loss for them to be affected. So I think that was really a little botched up over there as far as the health-related quality was concerned.
So I think we have come to the end of this session, and it was really as I said, it was really insightful discussion from I thank you, Dr. Harsh Kumar, for um, coming for this journal club meeting, and Dr. Manish Shah suggesting his name and coming to this session. And I would ask Zain to do the Thanksgiving.
Thank you one and all for this meeting. This is kind of a landmark meeting for us, because this is the last journal club for our MOS season 3, and we will hopefully be starting season 4 next year. But so a big thank you to everyone involved in this journey. I'll start with the panelists, Dr. Manisha and Dr. Harsh Kumar sir, for agreeing to be part of this journal club, and of course to our team, Vaishal sir, Sunny Sen Gupta sir, Parul ma'am, and me and Neeraj, who we've been kind of trying to make sure that we have kind of articles which are relevant and have importance for general ophthalmologists as well as the specialists. I thank Sampada and Rita ma'am for putting together this particular article. And Rita ma'am could not be here because of personal reasons, but she really helped Sampada prepare the presentation and gave her the insights on it. So thank you to both of y'all. I thank MOS and BOA, Santosh Bhide sir, president of MOS,
Santosh Agarwal sir.
Sorry, Santosh Agarwal sir, current president of MOS. We've been working with Bhide sir last year. Agarwal sir, president of MOS, and Balkrishnan sir, who is president of BOA. And lastly, I would like to thank NTOD, Rahul, who's always been there with for all the journal clubs and helping us with the technical aspects. So thank you.
Thank you for having us here. It was a wonderful meeting.
Thank you so much, sir.
Thank you very much. It was a lovely meeting, and I really congratulate the selection of the article was fantastic.
Okay, good night.
Okay, bye.
Thank you, sir. Good night, everyone. Yeah.